Since morning we are listening more and more on FACO. Now we are going to have the session in which you require more of surgical skill, that is the SICS and manual
Good
SICS
evening,
surgery.
everybody. Can I start?
Yeah,
So,
please, ma'am.
SICS is still relevant to us today. We think FACO is everything, but the tallest trees have the strongest roots. The advantage of SICS is it is a self-sealing sclerocorneal incision. The learning curve is less. It's a lower cost procedure than FACO. It's less machine dependent and less damaging to the endothelium. But the dilemma is that there is a 10 to 11 millimeter lens which has to be delivered through a 5 to 6 tunnel. So the difference between SICS and FACO is the sclerocorneal tunnel and the way you seal it. Everything else remains the same, and the conjunctival flap is also present in SICS. So that is what is different. So here is a very hard black cataract that you will be seeing, and in most of these cases, it is either the phaco time is more, there is lots of complications. So as you can see over here, this is a sclerocorneal tunnel which is made in an SICS wound. This is this is a funnel shaped incision which is made with a crescent blade. These black cataracts have leathery fibers, they are very thick. The ultrasonic time taken for these cataracts is high, and hence there is chance to damage the endothelium. These patients are very, very old too, and they do have compromised endotheliums. I would be still scared to do phacoemulsification in these patients. So these are the type of patients in which I would not advise, and I do not do phacoemulsification, and we are still faced with these kind of patients even today. As you can see, this is a cataracta nigra. This is the Blumenthal surgery being performed. And definitely this is an indication for SICS today. The surgeon is at peace, the endothelium is happy, and the patient is happy. Even though initially in phaco you may have good results, but over a period of time the endothelium will decompensate, and hence you need to reassess whether you should do phacoemulsification in these cases. This is the implantation of the IOL in this patient. So SICS also comes to the rescue if you have phaco complications where need to convert. So if you see this patient, we are doing phacoemulsification, it's a normal looking cataract, and you are leaving the zone of safety, which is the CCC, and before you know it, you have a complication and part of the nucleus falls inside the vitreous. You cannot do continued phaco because more pieces will fall in. As you can see over here, we were chopping in an unsafe zone and part of the nucleus has now fallen in. The rhexis is now extended because you want to deliver these pieces out, because you are not going to do phaco. In phaco, the rhexis would be smaller. So before we do anything, the rhexis is enlarged. A lot of viscoelastic is used to protect the endothelium, and now you can either suture what you do is you bring the nuclear pieces in the anterior chamber, extend this incision. Either the incision can be closed and a new sclerocorneal tunnel can be made, but even this can be extended and the nuclear pieces can be expressed. Now the advantage of doing this is that not many nuclear pieces are allowed to go inside, so that when the vitreoretinal surgeon takes over, a 3-piece intraocular lens should be implanted and a vitrectomy is done, and a pars plana vitrectomy can be done for the piece which has gone inside. So as you can see over here, basically, so you need SICS to help you whenever there is a complication in phacoemulsification, when you need extension to do this. So SICS remains relevant to us even today, where in cases where there is a hard black cataract, corneal opacity obstructing your view during phacoemulsification, pseudoexfoliation where there is subluxation. So SICS remains very, very relevant today in poor endothelial count, Fuchs dystrophy, post-keratoplasty cataract. Hence, SICS should not be considered inferior. It should be considered as a part and parcel of your armamentarium to do cataract surgery for any patient. And so it is very important to learn everything, to know all the techniques and use them to your benefit for the patient's welfare, to give them the best possible vision. Thank you so much. I think I finished in less than 4 minutes also, not even
Definitely,
5.
ma'am. Really thankful to you
Thank you,
for
sir.
finishing such a vast topic in short time. Now we have the next speaker,
Yeah, Atika.
Yeah,
Dr. Atika. Yeah.
thank you, sir. I thank AIOS for giving me this opportunity, and I'll be talking about how to create a good sclerocorneal tunnel. Like ma'am said, that creating a good tunnel is relevant in SICS. And without going into details, I would like to know that I would like to tell that the parameters which are important for structural integrity of tunnel are the self-sealing property which makes it unique. And a poorly constructed tunnel can be a source of irrigation, astigmatism, hemorrhage, corneal trauma. So it is SICS is a safe, simple, consistent, stable, and cost-effective way of cataract removal. But it is small incision is a misnomer because the external incision is larger than the internal incision. And a quick recap of the surgical nimbus, I would like only to emphasize that everybody knows what surgical nimbus is, that the incision should be given behind the mid-limbal line to avoid the trauma to the trabecular meshwork and to avoid DMD. The wound construction should be, I've divided into three parts: the external incision, the sclerocorneal tunnel, and the internal incision. The external incision should be created with a Ball-Parker knife or a disposable green plate, as we all do it. The location, shape, strength, length, and depth matters. And the astigmatism neutral funnel should be kept in mind while we create the external incision, and the ideal distance should be around 1 to 2 mm. So the length of the incision, it should vary from 5 to 6 mm for cortical cataract, and in case of compromised corneal endothelium, a large incision size may be made. So the primary deciding factor in the length of the incision is always the grade of the cataract as well as the size of the nucleus, and not the size of the IOL to be implanted. So the external incision, an optimal depth, as the length is important, the optimal depth is also important, and its thickness should be around half to 2/3 of the thickness of the sclera. Anything less can lead to a buttonholing, and anything which is deep can lead to a premature entry and a ciliary body damage. So the sclerocorneal tunnel, the sclerocorneal tunnel, the shape, the length, the width, the depth, and the side pockets are important. The central shape should be almost square with a corneal instruction, a limbal width, and a scleral pocket. And then there should be side pockets. These are the side pockets that give us the edge, and a larger nucleus can be taken out. So a diamond or metal crescent disposable knife has to be used. We hold the eyeball, we propagate anteriorly until it engages the limbus tissue. The crescent has to orient in upward and forward direction. And when we go into the cornea, the blade should be it should be held up. So there are two movements, the tadpole movement and the swiping movements. The tadpole movement causes the lamellar separation, and the swiping movements cause the cutting. The internal aspect of the tunnel is about 25% larger than the external incision, which gives us the edge. And the internal incision, when we make the internal incision, the entry should be very important. The entry should be sideways, and the dimple down technique should be used. So how should be an ideal SICS tunnel? Its location should be 1.5 to 2 mm from the anterior border of the limbus. Its depth should be between half and 3/4 of the thickness of the sclera, and the internal corneal lip should be around 1.5 mm. So the aim at the end of the day is to achieve a self-sealing, astigmatically neutral wound. So I have a video. Could you play the video, please?
This paper may be ready on the other side.
Dr. Purendra Bhasin is there?
So here the incision is created with the blade, and just the weight of the blade is given, and we with the crescent we revise it, and then we go forward with the tadpole movement and create the lamellar separation, and then we swipe sideways, the swiping movements, and create the cuts, and then we dissect the side pockets. The internal incision should be, the keratome should be entered sideways, and a dimple down technique should be used, and a forward anterior cutting should be used. I have another video. This is the same video? No. Yeah. So I have another video where the lamellar separation can be created in 3 quadrants, and then the sideways cutting can be done. So here the lamellar separation is created in the center, and then in the two pockets in the lateral extreme, and then these three are joined, and the care should be taken that the plane should be similar. So for the beginners, it is very easy to create a lamellar separation in the three quadrants, and then with care they can join the three lamellar separation.
But
They may be in different planes.
at the end, it may be
Yeah.
different plane and causing more of astigmatism.
Because
It
the-
may
I'm
be,
just,
sir,
I'm
but
just
it is,
suspecting. I don't do
it just-
SICS, I can't do.
But for the beginners, it is a bit easier.
Okay.
Sure.
Thank you.
Thank you.
Thank
I
you.
think-
So
Yeah.
now the next speaker is Shibashish Dev. He is going to speak on sharper focus, safer hands, patient safety in cataract surgery by trainee surgeons, safeguarding sight.
EV team, kindly start my slide over here.
Okay. Audio people, can you help?
In the
Meanwhile, Dr. Renuka Habib is here. Karamjit Singh,
Dr.
Surendra-
Sushil Oja is there, sir.
Dr. Sushil Oja, can you be ready on the other side? Thank you. And anybody present for the next, like Niruban Ji, Pradeep Kumar Mohanta, Janiel Patel, Vardhaman Kakaria, come on the front seats so we know that you are present.
So, hearty good evening to everyone here. My slides will be targeted to the very novice surgeons over here, to all my young friends. So, patient safety in cataract surgeries by trainee ophthalmologists, safeguarding sight. So, ultimately, this is the problem scenario. Globally, as you can see that in India, 62.6% of preventable blindness is still due to cataract. The purpose of this, my topic is to help the budding surgeons perform safe cataract surgeries. So why? Why is this topic important? Because it has been shown that, the various studies have shown that only 75.5% operated individuals get a near normal outcome after cataract surgeries. 24.5% suffer from low vision, out of which 5.1 are unilaterally blind, that is less than 3/60. The most common cause of unfavorable outcome was due to the intraoperative complications. That is why, what is our target? Our target is to see this beautiful smile on the patient once the bandage is opened on the next day. So, to my young trainees, you have to keep in mind that the patient's safety always comes first. So, for this, what are the stepping stones? First, you have to get a theoretical knowledge, get the skill lab practice, do the surgery and build your endurance. So, these are the stepping stones. So, for the theoretical knowledge, what do you need? You have to know the basic anatomy, both the surgical and the structural. Then you have to go know the basic surgical steps and the potential pitfalls for each step you have to keep in mind. So, the gears in your mind should always be keep working. So, theoretical knowledge, I have no financial interest. You can go through all, there are various books, good books are there available. New webinar platforms have also been launched by various sites, and there are various YouTube surgical channels. So, first and foremost is to know your instrument. First is to know your IPD, the ins and outs of your microscope that your respective centers are using, how to change the IPD, how to change the zoom, how to adjust the height of the microscope, how to do coarse focusing, how to do fine focusing. First, go from coarse focusing, then go to the fine focusing using the foot switch, then proper techniques. Usually we only learn what is the purpose of the instrument, but we skip on where these instruments, how to hold the instruments, that has to be learned. Pre-op is vital. You have to remember that what I teach my surgeons is, the surgery begins before the patient enters the OT theatre. You have to pick, for a beginner surgeon, you have to pick your battles wisely. First, you do a proper thorough ocular and systemic examination and pick those cases which are suitable for you. Say for example, you are not going to pick a dense brown NS4 cataract, you are not to pick a deep socket eyes, you are not to pick high myopia or high hypermetropia with shallow ACs. So those things you have to keep in mind. So at the end, a cataract surgeon is expected to master number 1, sterility, number 2, anesthesia, the surgery, and the complication management. The sterility includes proper hand washing, proper donning of the gown and the gloves, antiseptic dressing of the patients, and proper draping. Also during the surgery, you have to keep your third eye open and see whether your assistant is not making the surgical field unsterile, whether the supporting staff, whether the sisters of the OT are maintaining proper sterility. Those things have to be kept in mind. You have to master the anesthesia. Surgical steps, my previous speakers have made my job easy by giving such nice demonstration of the surgical videos. And complication management. The most important part of complication management is to identify when to stop and when to call for help. So these are the, shows the proper donning method of the gown and the surgical gloves. So identifying the problems of a trainee surgeon, there is poor hand-eye coordination, there is gross hand movement, there is problem in the depth perception, there is always a pre-op anxiety, unfamiliarity with the microscope, and going from a macro to a micro environment. So where does the problems, in the studies it has shown that most of the common problem areas are poor tunnel construction due to poor estimation of size and depth. There is problem in the capsular axis, that is maintaining the margin of the capsular axis, and in the cortical cleaning. So my advice is always to maintain the AC and keep in mind that a surgeon has 3 hands. That was what I was told in my PG. A surgeon has 3 hands, your dominant hand, your left hand, and visco. Always keep the AC filled with visco, and for complication management, do not go beyond the point of no return. Stop and identify, call for help, and analyze. The improvement strategies are wet labs, review of cases, and ICO Oscar scoring. Follow up your patients and try to engage with your mentor for the ICO Oscar scoring, which is available also in your Google Play Store. So these are the training methods that we use. We use there is assistant scope, and also there is AV teaching method. In advanced centers, there is cataract IC, there is a cataract surgery simulator, and develop your endurance. So there should be precise hand-eye coordination and develop your mental and physical fortitude to keep on doing cases. And this is my last slide. 6 mistakes that you should avoid: not knowing your patient, not knowing your instrument, poor draping and positioning, always try to keep the eye in primary position, bad incision, and not learning from every case. Thank you.
Excellent, Subhashish, and I must congratulate you for bringing out these points. The most important that when you sit, you should be comfortable. When patient lie down, he or she should be comfortable. If patient is not comfortable, he will keep turning his head, moving his head, and you will have difficulty, and you will go into anxiety or anger. The same way, if you are not comfortable, you will not be able to deliver what actually you can deliver. So take care of these things, and this makes your surgery really safe and comfortable. So excellent way, excellent points.
We have the next talk by Dr. Sushil Ojha, and he's going to talk on difficult phacoemulsification cases in small pupils, pseudoexfoliation, and traumatic cataracts. Dr. Sushil, sir.
Good evening, everyone. Just I want to highlight the importance of good, careful pre-operative workup, so that you know what can be the challenges you will face intraoperatively. There should be no intraoperative surprise. Like first case I will be showing of a small pupil. You know, there are multiple devices are available for dilating the pupil. So you should use the best dilator for the patient and also expertise of the surgeon. So in my case, I have chosen BHEX ring. So we should know not only the BHEX ring, but also the limitation of BHEX ring. It does not have a muscle power. So in cases of plastic iris where elasticity is not there, or a long standing posterior synecdoche, in that case the BHEX ring may not be successful. So in that case you should use iris hooks. But if there is recent onset uveitis, a recent posterior synecdoche, the BHEX ring will be a good option. See the size of the pupil. It is almost 3 to 3.5 millimeter. So in this case, what we have done, a visco separation of the posterior synecdoche. So we should be very careful before using Y or Sinski. We should use visco separation, because if you directly jump into breaking the Seineke, ultimately you are going to rupture the capsule also. So if we don't have a proper rhexis, then we will not be able to do phacoemulsification. So after doing stretching in both the meridians, horizontal meridians, we have inserted the B-hex ring, and we know the iris is not plastic, iris is looking elastic. So we have implanted a B-hex ring. Then the job gets, we get much job gets much easier. So you can see a simple phacoemulsification surgery is being performed. So you should know that it does not have a power like iris hook. So risk of sphincter tear is less, but simultaneously it will not be of use in plastic iris. So we have just completed simple phacoemulsification after B-hex ring. So after enlarging 2.8 millimeter incision, we have implanted a foldable IOL under irrigation. So you can see after implanting, I noticed that IOL was also tough, but we were able to separate the haptic without any need of viscoelastic. So we are separating the IOL haptic from the B-hex ring. So very easy to remove even from the side port. So we have implanted the IOL under irrigation, and post-operatively also after 1 week vision was 6/9. This is post-op day 1, and post-op day 7 around 6/6 vision is there in the patient. Key takeaways: we should have a good preoperative assessment, preoperative planning. So we should be prepared for multiple things which we will need in the during the surgery. So here I will be going to show some of the different cases. One case, there is mature cataract with extended rhexis. The resident was doing the rhexis and it got extended. Then the senior faculty took over the case. Another case will be mature leathery cataract, and the third case will be a mature intumescent cataract where we have performed a double capsulorhexis. So rhexis was started, and we can notice there is extension at around 2 o'clock position. So the senior faculty took over and started the rhexis from a different side, and use of microcapsulorhexis forceps rhexis is completed. The area which was left was completed with the help of capsulorhexis needle. So another case of a mature cataract. So we should have patience. It's a leathery cataract. We should wait for posterior plate to be broken. Then we should try to create the space so that undue pressure in the zonules is avoided, and try to complete the phaco in the bag. So we should have a patience till the posterior plate is broken, never in a hurry. Otherwise you will be in trouble if you want to partially eat the part of the nucleus and you have not broken the posterior plate or the endonucleus. Then you will be in trouble for the completion of your surgery. So this is another case, mature cataract. There is no support, so almost the nucleus is only present. So we should be very, very careful while dealing such cataracts. IOL scaffolding technique can also be used, and other methods are also described. But for experienced surgeon also should be very, very careful in such cases. Now the posterior plate is broken, so it is easy now. Carefully we can take away small pieces of the. So my last case. So here I am doing double capsular rhexis. We should try to decrease the intralenticular pressure by first by a small rhexis. Then we should try to do a larger rhexis after releasing the intralenticular pressure, so that we don't met any complication of extended rhexis or extension of rhexis beyond equator. So by doing a second nick, I have just enlarged the rhexis, and then your job becomes easy. The capsular rhexis is not going to extend beyond the equator. There is no positive pressure because we have already performed a partial IA from the small rhexis. Next steps are almost simple: phacoemulsification and implantation of a intraocular lens. Last case is cataract met with a PCR. So these are routine phacoemulsification cases. Thank you.
Thank you, Dr. Sushil. Do we have any more presenters here for this session? Any comments for these kind of difficult phaco situations or SICS from anybody, any audience?
Yeah.
Yeah, excellent presentations by all the speakers. So I think it's very important for us to understand the complexity of the situation, be ready with all your other things in your armamentarium so as to be able to take up any challenges in all kinds of cataract surgeries. So today we saw both SICS as well as phaco, both the early steps as well as the complex situation. So I'd like to thank all the panelists, the chairpersons, moderators, as well as all the speakers and delegates. Thank you so much.
Yeah, and thank you everyone for helping us finish in time. Yeah. We'll request all the speakers to please come for a group photo.